Hello, and welcome to this conversation on community access to effective antibiotics in low and middle income countries from the Trinity Challenge. My name's Marc Mendelson. I'm an infectious diseases specialist working in Cape Town and director of the Trinity Challenge, a UK charity founded by Dame Sally Davis in 2020 to identify data-driven solutions to help protect global health threats. Today, we're going to be speaking with two leading experts in human and animal health, exploring the two specific challenges to access to effective oral antibiotics in humans and animals in low resource settings. Specifically, we'll be focusing on the joint issues of antibiotic stock control and substandard falsified oral antibiotics in low and middle income countries, or LMICs, which are the subject of our current Trinity Challenge, which is calling for the brightest minds to bring low-cost data and technology solutions which will alleviate this burden in low and middle income country communities. Significant funding and support are available and for the most innovative solutions, and you can find more information on our website at www.thetrinitychallenge.org. I'm really delighted to be joined today by Pernette, Bourdillon, Esteve, and Jane Lwoyero. Pernette is a highly experienced technical officer at WHO, working in incidents and substandard and falsified medical products. She is currently finishing her PhD in global health from the University of Geneva and has previously worked for both UNITAID and the United Nations Office on Drugs and Crime. Jane is a qualified veterinarian from the University of Nairobi and went on to study veterinary public health. She's a One Health AMR and food safety expert working with the Ministry of Livestock Development in Kenya and the World Organization for Animal Health, WOAH, as an AMR and food safety program officer. So Pernette and Jane, welcome. Wonderful, wonderful to have you here. I'd like to ask you both a question. So Pernette, if I may start with you, what is it about your job that gets you up in the morning, apart from strong coffee? And can you briefly tell us a little bit more about your role at WHO?
Well, thank you very much, Marc, and thank you very much for having us. I just love my job, really. Very, very blessed to have a job that is it's very varied, very diverse. So, one day I can be helping my colleagues manage an incident of contaminated syrup formulations. The next day I can be discussing policy, for example, in relation to AMR. And the third day I can be talking about, community engagement. Because substandard and falsified medical products are such a cross-cutting issue, you get to do very, very different things. So you get to work with policy with member states. For example, WHO serves as the secretariat to the member state mechanism. You also get to work on things like social behaviors. You also get to work on things because it's also a criminal trade in aspect. So we get to work, of course, a lot with forensic scientists. We work with the UN Office on Drugs and Crime. So there's so many different things, and I get to work a lot on data, which is my big fave.
Wonderful. Sounds like a real portfolio job. So you have
Yes.
these many different aspects, which is always great.
And just one thing, sorry, I
Yeah.
think the thing that drives me most is with substandard falsified medical products, what really drives me is people expect to get medicines that work. And in so many places, it's still difficult to make sure that people actually have access to medicines or vaccines, etc. And they sometimes sacrifice quite a lot to get access to health treatment. And when that doesn't work, there's a whole range of socioeconomic indicators, and that really, really gets me when you think that there's still so many people in the world who get by on $2 per day, and they've got to stop working for one day to get an anti-malarial or an anti-cancer treatment, and then that just doesn't work. That's what really grips me.
Absolutely. No, you should be getting what you're paying for, but also what you're expecting for and need. So it is, yeah, it's really important. Wonderful. And Jane, same question to you. I mean, what gets you up in the morning? The birds, the coffee, I don't know, but can you tell us a little bit more about your role at WOAH?
My role at WOAH as the AMR program officer is to support countries in implementing the WOAH strategy on antimicrobial resistance and prudent use of antimicrobials. So within this role, I get to work with countries in the sub-regional representation for Eastern Africa in helping them implement the animal health components of their national action plans on AMR, and specifically issues like how to collect data on antimicrobial use and different interventions that WOAH supports the country in terms of putting measures in place and implementing international standards relating to antimicrobial resistance, both through surveillance, monitoring, training, advocacy, and as well as collaboration together with the quadripartite partners, that is WHO, FAO, and UNEP. Yes.
Fantastic. Are you a coffee drinker?
Unfortunately not even a tea drinker, because I have to stay caffeine free.
Okay. But Kenya does make some very good coffee, so
Yes,
and
it
for other
does.
countries. Okay.
Yes, it does.
Wonderful. Okay, so Pernette, if I could start, with some questions for you, and just because our audience is varied, and it's important just to get a couple of definitions straight from the WHO. So WHO defines substandard medical products, also called out of specification. These are authorized medical products that fail to meet their quality standards or their specifications, I guess, or both. Whereas when we're talking about falsified medical products, these are deliberately or fraudulently misrepresenting their identity, composition, or source. Just as you said, people expect something, but they're getting something fraudulently misrepresenting. So with that in mind, this is a real problem in low middle income countries and in our communities. So how do we currently monitor for substandard falsified antimicrobials, antibiotics, let's say, especially in low middle income countries?
Well, thanks, Mark. So just the definitions are absolutely correct. I would just add, for falsified products, the WHO definition does not take into consideration intellectual property rights. And this is actually quite important for us, so I'll just remind it. And both substandard and falsified products, at the end of the day, people are not getting what they should be getting. So to be a little bit provocative, from a public health perspective, it almost doesn't matter. They're just not getting what they should be getting. And how do you monitor these? Well, I'd say you monitor as for any other medical product. It's not because it's an antimicrobial that you might monitor slightly differently. We'll get into those tweaks. And same thing for the low and middle income countries. Regardless of a country's income level or resources level, you've got to monitor the quality of the product circulating in your supply chain equally. And that responsibility falls predominantly, but not exclusively, on national regulatory authorities, national health regulatory authorities. And I'll talk about this a little later because I know what questions you want to ask me. But we've got to monitor the quality of things that are circulating through a physical supply chain, the commodities, the actual commodities. You've got to make sure that things don't degrade whilst they're circulating, and you've got to make sure that the bad things don't come in. But you've also got to make sure that the information is coming back to you. So there's the information supply chain as well, not just the physical commodities supply chain. And in order to monitor the quality of products in a given market, it's all about making sure that you get the right information from the right people at the right time. So we encourage national regulatory authorities to have very good open communication channels with those who are at the interface between the product and the patient. And that's often pharmacists or healthcare providers where you can get them. What's interesting with antimicrobials and substandard falsified versions of those is that they can kind of be mutually early warning signals for each. So if you've got AMR somewhere, it might be that there is a link between substandard and falsified medical products that have been circulating for some time before. So if you find substandard and falsified medical products somewhere, you might want to put in place the same monitoring mechanisms for AMR so that you catch it on quite early. Basically, substandard and falsified medical products could be an early warning signal for AMR because some of the driving forces are similar. Let me know if you want me to elaborate or not.
But so that's a really interesting point, because it's not an absolute, is it, that substandard falsified products will lead to AMR. I mean, if you've got a falsified product with nothing in it, it's not going to generate AMR. And so that's a complexity of this and our understanding. I mean, do you want to just say a little bit about that?
Yeah, that's a really good point. And that's the beauty of public health. You've got to take things within the context of a system. So if you've got a substandard or a falsified medical product that has penetrated the supply chain and even worse, reached patients, you've got a failure of the system. And with AMR, it's not a failure of the system, but things are not going kind of as planned. So when you have a falsified product, things will not be going as planned. And you'll start to have things that come into your modelization, come into your plans, which will start getting different. So all your predictions for how an infection might evolve might get skewed off if you've got all of these substandard and falsified medical products coming in. You mustn't forget also that when you've got a substandard or a falsified medical product, it's not just one dose that matters, especially with infections. You tend to take a treatment course, a treatment regimen. So if you're unable to guarantee that one dose is of the right quality, and et cetera, how can you guarantee that the rest of the treatment regimen is right? And it comes back to, well, everything else in public health. You know, are people adhering to their treatment in the right way? So this is where, you know, public health is so interesting. You've got to go back to social behaviors, adherence. How do people perceive access to medicines? Do they perceive access linked to quality, et cetera, et cetera?
Oh, yeah, absolutely. You know, a really interesting field. We probably could spend the entire time speaking on each of these individually. But so with that in mind, I mean, what are the main barriers to understanding the nature and scope of substandard and falsified antibiotics in the low middle income country community setting in particular?
But, you know, someone once said it's the economy, stupid, or something like that. And I'd say it's the information. It's always the information supply chain. By definition, substandard and falsified medical products are a hidden trade, right? A falsified product, the people who are manufacturing and distributing those will do everything to conceal the nature of those products. So by definition, it's difficult to spot. And with a substandard product, well, sometimes you don't really realize that something is wrong unless you've got a very obvious adverse reaction. And it's important to say that not all adverse reactions are caused by substandard and falsified medical products, but not all substandard and falsified medical products cause an adverse reaction. So detecting these is really, really difficult. And then once you've detected it, it's not enough to have detected it. You've got to make sure again that the information goes back to the right people. And in low and middle income countries, sometimes that information supply chain will have missing links. And that's what is, I think, one of the main barriers. If you don't have enough evidence, you can't understand what the problem is.
Mm.
Missing
Okay,
data means missing knowledge.
Yep, true. So with that, again, with that in mind, I mean, why is data collection at community level so difficult and challenging? Can you elaborate on what you think the main challenges are? And, you know, what are the innovations in data capture and analysis that you think, you foresee actually shifting the dial on this?
So I think one of the main challenges is the human resources in public health, especially in low and middle income countries. Public health officials, and I you know, very broad definition of a public health official. It can be anything from a community pharmacist to a nurse to an admin assistant in the National Regulatory Authority. These people tend to be overburdened. You know, they're doing 10 jobs at once. They're very dedicated, but they don't have enough time to do all their work. And they're often being asked to input data into lots of different forms at the same time. You know, there's the famous story of the midwife who's, after having helped a woman give birth, has got to fill out 3 different forms, you know, one for the international donor, one for the Ministry of Health, one for something else at community level. And these 3 different forms often have got the same piece of information. So it's all about connecting the data sets rather than asking people to fill in the same piece of information at the same time over and over again. How do you capture in a single go the information that you need, kind of real time? And how do you make sure that the information that you're capturing is actionable? You know, that it's all very well to say, I've got a problem with a medicine. You know, what's the problem? What's the medicine? What action can you take? And I think one of the challenges as well that you have at community level, but also at wider level, it's having acceptable alternatives. You'd be surprised at how much people are ready to take a chance. I'm saying, well, yes, maybe it's a little bit substandard, but I've got nothing else. I'm ready to take a chance. If you don't have an acceptable alternative, you will not shift behaviors. And this is not just in low and middle income countries. Look at treatment-seeking behavior of people online. If they're not told that this is maybe not the great option, but they have nothing else, they will continue to in that particular direction. So I think that's one, in terms of data capture, I'd say the innovation would be, how do you capture in one go the information that can be used by lots of different stakeholders at the same time and almost in real time. In low and middle income countries, you'll continue to have challenges with digitalizing the data sets, connecting them to one another, and internet connectivity. And one last thing, this is not just in low and middle income countries, but especially in theirs, there is a perception that absence of evidence is evidence of absence. So if they don't report, there's no problem. And because substandard and falsified medical products signal a system failure, they do not want high levels of substandard and falsified medical products, quote unquote, prevalence to be associated to a failure of what they're able to do. And we keep trying to tell people, this would really, really change the dial, is that high levels of reporting are indicative of high capacity to detect and report. So this is really where we need to shift the dial. If you're reporting, that means you're able to do something about it, and you probably are doing something about it. But too often, people associate high reporting levels to a stigma, I would say, in public health.
So that's great, but just one other point about this. I mean, these falsified medicines are difficult to spot often. So, you know, they can be very close to the packaging can be very close, the actual tablet can be very close. So what sort of innovations, I mean, if you were really going to, you know, if you had a lot of money and you were going to do some blue sky innovation or even just standard innovation that you felt would actually help identify and help those small number of people that, of course, are trying to identify these to actually do so?
Obviously, you need to increase lab capacity. But even if you had very strong lab capacity, let's be realistic, you can't test every single product systematically. So you need to have risk-based interventions. And to have risk-based interventions, you need to know what type of risks you're targeting. You also must kind of balance overall testing and making sure that the products are available at the right time. You don't want to withhold or slow down the supply chain for excessive checks. One thing that I would love to see, and I don't know if we're getting into the innovation Trinity Challenge innovation, is I'd like to see image recognition capacity deployed at community level so that people could take an image, a picture of a product which they might find suspicious, and they could see whether that image matches something that has already been confirmed to be substandard or falsified, and or whether that image may match something that is in the authorized registered database. So there's a lot of products that are circulating which might not be registered. A not registered product is not necessarily bad, but if you had image recognition, it would certainly collect data automatically, and you'd avoid dual reporting in some cases.
Well, a great idea for everybody out there as a
you could connect it to the alerts that WHO has issued. You know, does this match something that we've already issued about?
Indeed, and just remember to assign, you know, thanks to Pernette for that idea if you are going to use it. So again, bringing this together, so the WHO, you promote what you term a prevent, detect, respond strategy to tackling this issue. And you also mentioned the stock control in passing just there in your answer. I mean, stock control and substandard falsified antibiotics can be fairly, interlinked. I mean, how do they collide in this challenge that you're facing?
That's a really good question. So at WHO, we've been collecting data on these types of products for about 10 years now. And it's helped us understand what are the main driving forces. And the main driving forces are basically constrained access, poor governance, and weak technical capacity. And under poor constrained access, you've got affordability, availability, and acceptability. So if if a product is not available, say you've got a shortage because of stock control, like I said, people will turn to any other available and acceptable sources that they can find. So basically, if you've got constrained access, this is going to push people sometimes outside safe procurement routes. And that's how they collide. Do you want me to explain the prevent, detect, respond a little bit more, or?
Yeah, that would be great. Just a little.
So we've got these three driving forces, access, governance, and technical capacity. And in order to address this, WHO has developed a prevent, detect, respond strategy, and these pillars are declined into 12 functions, which I won't describe now, but it basically is, first of all, you've got to make sure that everybody demands quality. And this goes from wholesalers, distributors, who should be doing their due diligence, but also to the end users. So, for example, trying to purchase cold chain injectable medicines from social media is probably not a good idea. And that's where demanding quality comes in. Under detection, I've mentioned this before, you've got to help people detect the issues quite quickly. And this goes with lab capacities that can be declined, rapid testing to more quantitative testing. And once something has been identified as a problem, you have to be able to report it. And you've got to make sure that the right people are able to detect the problem. So sorry, just going back to under prevention, it's about the supply chain integrity. The bad things must stay out. So, for example, a customs officer must make sure that something bad doesn't penetrate the supply chain. So, customs officers must be given the tools to detect early on. And that can go through image recognition or other types of screening devices. And then it has to be reported to the right authorities so that they can take action. And under response, the first thing is you've got to protect public health, giving them alternative treatments if that's necessary. And then you have to prevent recurrence. And under preventing recurrence, that's really multi-stakeholder collaboration, working with the judiciary, working with the law enforcement, et cetera, et cetera.
Fantastic. So one last question. The Trinity Challenge is very interested in how we integrate data sets, and we know that climate change is going to pose a real, very great challenge actually to particularly quality antibiotics that may become substandard because of changes in our climate. In fact, a patient of mine recently went cold turkey because a tablet that she was taking, she kept in a bathroom and it was very hot over a week's period, and the tablet just completely changed color, and her symptoms were terrible. So with that in our future, what are we going to do to try and mitigate this issue of climate on our medicines, and particularly on our antibiotics?
That's a really good question. So with antibiotics, obviously there are lots of acids. Sometimes, with the beta-lactam inhibitors, which are vulnerable, the way in which you condition the products, whether it's aluminium, or plastic and aluminium, is going to have an impact. But not just. The example that you gave of a tablet sitting in a bathroom, that's the same thing for containers. Can you imagine a container full of antibiotics that might have, because of price considerations, might be at the very top of the ship, right where the sun is hitting strongest, and it's traveling by sea for a few months, several weeks, and then it might sit at port before it's being cleared. And at the harbour, it's also going to be sat outside in the hot sun. So I think that's one of the challenges for quality control of antibiotics with substandard falsified. But the other thing as well is how climate change events, natural disasters are becoming worse and do impact the infrastructure, the logistics. You'll have roads that will be drowned, that will not be practicable. And that means that bringing the products to the right people at the right time will become more difficult as well. So it's not just the direct impact on the product's degradation, it's also bringing the products to the people.
Yep, and absolutely. And again, a really interesting area potentially for innovation, as you say, in the way we think about how we get the product to patients, to people who need, the public who need it. Fantastic. For the moment, Pernette, I'm going to move over Jane to let's talk food security. Let's talk animal health and AMR. And I think to start off with, perhaps can you explain for our viewers how community food producers in low middle income countries actually access antibiotics for their livestock and for agriculture?
Thank you for the question. And from where I sit, I see community food producers in most low and middle income countries accessing their antibiotics from the retail shops, which we call agrovet shops in our side of the continent. And these are the small shops where they stock veterinary product and agricultural inputs. And another source of antibiotics would be from the animal health service providers who treat animals, and therefore they might be having a small briefcase that they use like their toolbox when they go from farm to farm visit to look at animal health, or when called in by the farmers themselves. And also some of our animal producers, they'll get medicine from their neighbors or on market days in places where you find places where still veterinary medicines are sold in marketplaces. So they'll still find it there, just in an open air market, and they buy it and they go home with it, especially if they've ever used it before or they think their neighbor has used it and they have explained to them their experience while using the medicine and they think they need it. So they buy it and they take it home with them to treat animals.
So would those be identified in the market, do you think, as a veterinary product, or is it just antibiotics on the market stall that could be for anything?
They range from a veterinary product, antipyretics, all types of medicine, antihelminthics, everything can, in some places, can be found from the market. But then that is in the very rural areas of countries. But then as you come towards the urban and peri-urban areas, then there are more organized setups where you find the retailers for veterinary medicines, the stockists that sell to the retailers who buy and sell to the end users. And then you also find the manufacturers and wholesalers. But then as you go lower the supply chain and lower into the production systems, the availability of these medicines becomes scarce because of how far the farmer is from the nearest animal health service providers and also from the nearest town center where they can actually get the medicines from.
And Jane, how much of a problem is having antibiotics in food or in water that's given to animals as just part of the food and water, not actually knowing, the farmers may not actually know that they're getting antibiotics? Is that a major issue in the communities in low middle income countries?
That would pose a big problem because first, we do not consider, most communities do not consider that the water that they give to their animals should be the same quality as the water that human beings use. So they think animals can take anything so long as it's considered water. Nobody would think of the health hazards that bad quality water could be to animals. And they also do not have the understanding that whatever they feed their animals would then impact on the quality of the animal products that they then put on the market. So a lot of awareness creation and sensitization about the proper way of handling medicine and what should be given to the animal as a result of looking at the safety of the animal product that will then end up on our plates is important.
Absolutely. So Jane, what are the particular challenges, do you think, in the supply chain for subsistence farmers and even those with larger food production capacity in low middle income countries?
There are a number of challenges that the supply chain within these settings has encountered. And the most prevalent one would be stockouts. And especially, as I said, the more you move towards the rural areas, then the unavailability of specific antibiotics becomes evident. You could access several molecules in town centers and urban areas, but then as you go down, some of the molecules would not be available, simply because at some point, some of the antibiotics that would be used to treat most of the animal diseases that, like from the WOAH perspective, what we have seen being used most are the tetracyclines and penicillin streptomycin combination. So there is a penicillin streptomycin combination that requires a cold chain facility. So as you move away from the urban areas, then the stockist or the retailers down the line might not have the refrigeration facilities, so they might not stock it. And if it's required, then it will not be accessed, not because it's not available or registered for use in a country. It's just because the people who are stocking then cannot be able to stock it because of the storage that is required for it. And also the unavailability of specific antibiotics could be because the farmer is keeping a certain species of animal for which we do not have a registered antimicrobials for use for that specific species. This is because maybe the numbers of the species that are kept in the country are low to make any economic sense. So there's no veterinary medicine supplier that has seen the need to register such antibiotics for use in the country. So they will not be available just because the quantities used in the country do not make economic sense for a drug to be registered. So the other problem would be for the substandard and falsified medicines. And these we have seen not necessarily because of stockouts, although stockouts potentiate the opportunity of these molecules circulating, but also they are there in competition with trusted brands because of unscrupulous business people trying to take advantage of the market that is readily available for this trusted brand. And therefore, if people are not able to tell the difference, then they'll buy it while thinking it's the trusted brand that they have used before, or the others that has been in the market. Then we also see another problem of disposal of the unused of expired medicine, because there are no procedures in place and guidelines on how this should happen. Then farmers end up just throwing together with the rest of the waste. Therefore, there's contamination of the environment with these molecules that are thrown without regard. And also a black market where we have illegally, the illegal medicine getting into the supply chain. So these are not registered in the country, and they might be registered in neighboring countries, but then because they have not been registered in one country and they get into the market, the farmer will still get access to them. So yeah, those in brief would be the challenges.
Yeah. No, thank you. So I mean, I'm guessing then if there are stockouts, as you had discussed before, probably subsistence farmers would get antibiotics from informal sellers in marketplaces or borrow from friends, etc. But I mean, how do we have again the challenge, and again the challenges relating to substandard falsified medicines in human health, I take it, are the same in animal in the animal health and the food security issue, because again, we don't have the resources perhaps, but are there monitors who are really looking at this in each country for animal health, for veterinary products? Is there surveillance in food production systems for substandard and falsified medicines?
It is there, but on a very small scale, and especially for what we know is from the efforts that WOAH has put in place to start the monitoring and surveillance for such products. And it has started with some pilot countries. So like in Africa, we have around a few countries that are already voluntarily gotten into the have voluntarily accepted to be part of the pilot countries for monitoring for substandard and falsified medicines. When I was discussing stockouts, I did not mention also, like when there are stockouts for veterinary medicines, most farmers will go to the pharmacies and buy human medicine and use it instead, because they'll look at something that is closely related. And we have such a problem because of the case where you have animals where the medicines cannot be found, especially like small animals like dogs and cats, where they would just use the human amoxicillin and others to treat conditions in cats and dogs. So, and apart from that, also from getting from the neighboring countries that come from the unmanned border points, so they'll still get there. But then as we have the circulation, it's because there's demand for this medicine and people have to find them wherever they'll get them, so they'll go for it.
Absolutely. So again, with this in mind, so what type of innovation, bearing in mind about the Trinity channel, what type of innovation in data analytics do you think is needed to better support sustainable access to effective antibiotics for veterinary purposes for communities and farmers and agriculturalists in low middle income countries?
At this point in time, I'm looking at the ability for us to collect data at the lowest level and for us to be able to create that awareness amongst the animal health workers and the farmers on the possibility of circulating substandard and falsified veterinary products. I have seen some awareness going on, although it hasn't gotten to the magnitude to which it needs to be. But then the use of the community animal health workers to link up with animal health service providers so that they can be the go-between the farmers and the veterinary service providers, for me, that would be important. And if the community animal health worker can have a mobile enabled app that gives them the database for where the nearest service provider is, then they are able to link up these people with the farmers first, because they need to be able to get prescriptions for antibiotics that need to be used. And therefore, after linking to the veterinarian, then the veterinarian can then also link to the nearest animal health service provider. It doesn't have to be a veterinarian. It could be an animal health, a veterinary paraprofessional who then can administer the medicines, because these ones, the veterinary paraprofessionals are many and they are more accessible to the farmers than the veterinarians themselves. So a tool that links up all these people for information and also for action would be important to help. And I'm also looking at public-private partnership engagement, where within a country, the government could have an initiative to bring together the private sector in the veterinary medicine supply chain so that they can quantify the antibiotics that they need to use within a specific time. So this information is then shared with the private sector, and because the private sector would benefit from this knowledge in making their investment because they want return on their investment, and then the government will be benefiting because then they get to know the information from what is imported into the countries, what is sold, so that they push the initiatives for responsible and prudent use of antimicrobials, at the same time monitor what is used in the country. Thank you.
Fantastic. So as a last question to you both, I'm going to be a bit cheeky because both of you have actually sort of told us that one of the main innovations that's needed is in data collection at the lowest level. And you, Jane, you were just mentioning, that yourself. And interestingly, in the Trinity challenges prior to this, the first two, one on pandemic preparedness, one on antibiotic resistance, community health workers and equivalent in animal health have been part of the solutions. So I'm going to say, okay, let's agree that you need better data collection and maybe an app, and as we said, who we're going to use. But to both of you, I'm going to pose a final question. If you were going to enter the Trinity challenge on community access to effective antibiotics, what would your innovation be? And I'm going to come to Pernette first and put you on the spot. And it can't be data collection through an app on by people in the community.
No, and to be honest, I'm not sure that data collection through an app is something that I would promote, because there's no shortages of apps. It's kind of, who uses them and then what's done with the data. I'd probably go back to what I was saying earlier, which is if we could have a tool that could help people recognize with a single image whether a product has already been the subject of a WHO alert and or whether a particular product is authorized, registered within the market where it's being distributed. I think that would be really helpful. And it would go back to linking the community level with the authorities, because we're talking about data and things like that. Even though, of course, I love data, I think I love people even more. But sometimes not always. Just go back to my Excel. And connecting databases is really about connecting people, and in big organizations, or not even sometimes in big organizations, there's a lot of invisible work that's done by people who coordinate, who go and speak to someone from another team and things like that. And that's what connecting databases is about. So if you could have an application that could say, hang on, I've already seen this somewhere, and you might want to, raise the profile, that could be quite interesting. And you can think about either connecting it to, like I was saying, products that have been registered at the national authority, or things that WHO or others have published about, or connecting it to existing databases like the pharmacovigilance database. There's all sorts of things that could be done. And I think, again, with community level, if you can have stuff that's based on images, and then you use optical character recognition to do the data link.
Fantastic. So now we know that it's not just people, but it's also your Excel spreadsheet that gets you up in the morning. So that's good news. Jane,
And my
over
kids.
to you. And your kids, of course. Jane, over to you. What would your innovation be if you were to enter the Trinity Challenge?
I would still go back because within animal health, this data is not being collected. And even at that lower level, people still do not even know that there would be these different types of medicines circulating. So for us, it's about getting the groundwork and connecting people as we collect that data for the system to work. Because being frank enough, there's no system in animal health.
Well, a very important call. So, and thank you. So really, to both of you, Pernette and Jane, thank you so much. And to your organizations, the World Health Organization and the World Organization for Animal Health, for giving us your time and for the expertise you've brought to this, and giving our audience some thoughts about, what this area really needs to, how it needs to change, and what the important challenges are. I mean, it's clear that there's much to do to improve community access to effective oral antibiotics in both human and animal health. And I hope the conversation's given some insight into that and how we need to act and how important it is now. If this has inspired you to act, perhaps you and your team could be part of the solution. So if you have a low-cost data and technology solution and that could improve either antibiotic stock control or substandard falsified antibiotics, oral antibiotics, or both in low and middle income countries, and we want to hear from you. The Trinity Challenge on community access to effective antibiotics is open until the 24th of April 2025. And once again, that website for more information is www.thetrinitychallenge.org. And we really look forward to receiving your application, your solutions becoming part of the mitigation strategy for really this challenging area. But for now, thank you, and thank you for joining us.